So bones of the lower limb. So as I said, the pelvic region going down to the femur, which is the thigh bone, which then joins to the knee on the patella, which then further down goes to the tibia, fibula, the ankle, and then we have the foot bones. So let's start with the femur. So the femur is the only body in the thigh and the longest bone in the body, as I'm sure you all know. It acts as a site of origin attachment of many muscles and ligaments and can be divided into three main parts. So the proximal part, the shaft, and the distal part. So you can cut it into three major parts. This proximal part, it articulates with the acetabulum of the pelvis, which forms the hip joint. So if we look at this picture here and you've got this pelvis, a closer view would be this photo. So this is the proximal end of the femur articulating with the pelvis at this area called the acetabulum. And the proximal femur comprises of the head, the neck, and two bony processes called the greater trochanter and the lesser trochanter. So you have the head, the neck, the greater trochanter, the lesser trochanter, and you've got this intertrochanteric line, which connects the two trochanters. It runs inferior and medially on the anterior surface of the femur. And this head, as we mentioned before, it articulates with the acetabulum of the pelvis, which is a smooth surface covered with articular cartilage. And then we've got the neck, so this bit, which connects the head of the femur with the shaft, so the body of the femur. And this allows the hip to move in different directions and allows for an increased range of movement at the hip joint. However, this femoral neck is very narrow, and so it's a point of structural weakness, which is why we'll cover later on. A lot of patients can have fractures at the neck of the femur because it's a point of structural weakness. The greater trochanter, it's the most lateral palpable projection of the bone, also at the anterior aspect of the femur. And it's a site of attachment of many muscles, which we will cover later in the talk, some of which include the gluteus muscles of the hip. Then we've got the lesser trochanter, which actually projects from the posteromedial side of the femur, inferior to the neck. And it's also a site of attachment for some muscles, one known as the Iliofemoral muscle, which we'll cover again later in the talk. But the key thing to know about this bit is that the neck of the femur is a weak point, which is prone to fractures, primarily, which can happen at any age, but commonly in the elderly. So here's just a picture that again just highlights the main points of the proximal femur that you should familiarize yourselves with. And we will go on to the distal femur. So the distal femur, which would be at this point, it articulates with the proximal end of the tibia, which is this bone of the lower leg, which forms the knee joint. So the key anatomical points which you should be familiar with are the medial and the lateral condyle. So these are rounded areas at the end of the femur. They lie at the posterior and inferior surface of the femur, so at the posterior and inferior surface, and they articulate with the tibia, and also the meniscus of the knee, which we will cover later on, which is basically the cushion of the knee. You also have the lateral epicondyle and the medial epicondyle, which don't directly articulate with the knee, but they're also bony elevations of the distal femur. So is that clear for now, what we've spoken so far? Okay, great. So we'll move on to the next bit. So we'll move on to the hip joint, which is related to the proximal end of the femur. So the hip joint just up here. And does anybody know what type of joint is the hip joint? Just take a guess. And you can send me your answers privately if you'd like as well. Okay, that's correct. So it's a ball and socket synovial hinge joint, which forms between the pelvic acetabulum and the head of the femur. So you all got that correct. And it connects the lower limb to the pelvic girdle and is primarily designed for stability and weight bearing. The functions of the hip, it can flex, it can extend, it can abduct, which means that it can move. Abduct means it can move outwards laterally, and adduct means it can move towards itself medially. And with the hip, the medial and the lateral rotations are a bit more restricted than other joints. So we'll just talk a bit more about this fossa here. So this acetabulum fossa that we've mentioned about earlier is deepened by this acetabular labrum, which is basically a fibrocartilaginous collar. And so the head of the femur is hemispherical, and it completely situates itself within this concave acetabulum. So all three pelvis bones, the ilium, the ischium, and the pubis, contribute to the acetabulum. And the socket is incomplete inferiorly, as you can see, and this gap is known as the acetabular notch. There is a central depression here in the acetabular fossa, which is made of a fibrofatty tissue, and it basically minimizes the contact stress between the femur, between the joints where it meets. And we also have this ligament which connects the femur to the acetabulum, the hip joint, known as the Ligamentum Teres. So a ligament is a short band of tough or flexible fibrous connective tissue, which connects two bones or cartilages and holds together a joint. So we'll go through the main ligaments of the hip joint capsule that you should know. And so it can be classified into two different groups: intracapsular, so what's within the capsule, and extracapsular, what's outside the capsule. So intracapsular, as we mentioned before, is the ligament of the head of the femur, which basically connects the femur to the acetabulum, the acetabular fossa to the fovea of the femur. So the fovea of the femur is a depression. It's a depression in the femur where this ligament arises, and around the area is a branch of one of the arteries, the obturator artery. And then, so that was the ligament on the head of the femur. So we look at the extracapsular ligaments now. So we have the iliofemoral ligament here, and this arises from the anterior inferior iliac spine. So I've got this little picture up here, which if you zoom in, this part of the pelvis is the anterior inferior iliac spine. So it's somewhere around here. And it bifurcates. It's this Y shape that bifurcates before it inserts into the intertrochanteric line of the femur. I should have mentioned before, just during the talk, we are using as many cadaveric images as possible just to get you so that this looks like a realistic anatomical session rather just the pictures that you'd find on the internet. So it may be hard to identify at first, but it'll get you a bit more familiar with the real life anatomy. So as I said, it's a Y shape. And then you have the pubofemoral ligament, which is here. And this is between the superior pubic rami, which is here. And again, the intratrochanteric line of the femur. And this is a triangular shape here. And it prevents excessive abduction and extension. And then we have the ischiofemoral ligament, which lies posteriorly, so you can't appreciate it on this image. And it lies between the body of the ischium and the greater trochanter of the femur. So these are the main ligaments of the joint capsule. And as I said before, the femoral neck is a structurally weak point, which is prone to fractures, which is seen in a lot of the elderly population, but can also be seen in young adults as well. And you can get two types of fractures. You can get an extracapsular fracture and an intracapsular fracture. So an extracapsular fracture is a fracture that happens outside the capsule, so not within this bit. It's in the outside. So if you look at this image here, you can appreciate a fracture. So that's extracapsular. And if you look on this image here, you can appreciate this is where the intratrochanteric line sits. So this is counted as an intracapsular fracture. So what's clinically relevant with these neck of femur fractures is that the blood supply to the femoral head, it travels along the femoral neck. So if you have a fracture that goes through the femoral neck, it disrupts the blood supply to the head of the femur. And if that's not repaired, it can cause avascular necrosis. So these hip fractures need to be fixed surgically. And also the major blood supply to the head of the femur arises from the obturator artery, which is a branch of the anterior division of the internal iliac artery. So if blood supply to the femoral head is preserved, so a general rule of thumb, if the fracture happens outside the capsule in the extracapsular region, it does not disrupt the blood supply to the femoral head. It's primarily if the fracture happens in the intracapsular, so through the intertrochanteric line, that you get disruption of the blood supply. So if the fracture happens extracapsularly and blood supply is still preserved, you can fix this surgically with just plates and screws. However, if you have an intracapsular fracture and the blood supply has been disrupted, then you have to replace the head of the femur with the prosthesis. So and that's what's called a Hemi Arthroplasty. So hemi means one side, and arthroplasty is a new joint. Or you can do a total hip arthroplasty, which replaces the bone and this part of the pelvis as acetabulum. So the entire area gets replaced. Yes, so someone's asked a good question. I was just going to talk about this in the next slide. You can have an intracapsular fracture where the blood supply is not disrupted. Fractures can be either displaced or undisplaced. So a displaced fracture means that the bone breaks into 2 or more pieces and it moves out of alignment. So if we look at this image, this bit and this bit were displaced. So this was replaced with the Hemi Arthroplasty. But in this picture, where the fracture a fracture still happened in the intracapsular region. However, because the bone was not displaced, the blood supply could still was not fully affected. So this can be fixed with plates and screws. And generally with an extracapsular fracture, so fracture happens outside the intertrochanteric line, they're generally fixed with plates and screws. So that's a great question. So we'll just look at a case together. So this is a typical story when you're in your orthopedics placement. An 82-year-old nursing home resident has a fall and lands on her left side. So we're looking over here. She was unable to mobilize, and the typical picture you'll get is the right leg, the leg is shortened and externally rotated, and she's complaining of severe pain. Can anyone tell me whether this is intracapsular or extracapsular? And then the next question will be, is it displaced or not displaced? Yep, intracapsular. And is it displaced or not displaced? Yep, intracapsular is correct. Yeah, so this is a displaced fracture. If you see this part of the femur has moved on top of this part. So the blood supply that's running through this neck would have definitely been affected. So would this fracture be fixed with a total replacement, or would it be fixed with plates and screws? Yeah, so a replacement. So this is a hemiarthroplasty, where the femoral head is replaced with the prosthesis. And so we have another case. Here we're looking at a young patient. So a 22-year-old cyclist fell off his bike at a high speed. He's complaining of severe left hip pain, unable to weight bear, but he is neurovascularly intact. So is this intra or extracapsular? Yep, so this is extracapsular. And with this, how would you fix this? Yeah, plates and screws. So this just needed screws to be fixed. Yeah, perfect. So just to go back, you won't need to know this for second year, but just you'll need to know this eventually. So this is a hemiarthroplasty where just the head of the femur was fixed. And typically in the elderly population, this is not a total hip replacement. This is just a hemiarthroplasty. A total hip replacement would be when the capsule here, the part of the hip is also replaced. So generally in the older populations, just due to frailty and all that, you just do hemiarthroplasty. Whereas if you have an intracapsular displaced fracture in a younger patient, they would go through a total hip replacement because they're more fit for it and it would last them longer. So just over here is the fracture line. Okay. So moving on from the hip joint to the knee. So we'll work our way downwards. Everyone happy with the hip and the neck of femur bits for now? Okay. So now down to the knee joint. So can anyone tell me which of the following is the correct classification of the knee joint? Is it a hinge type, plane type, pivot type, or ball and socket? Yeah, perfect. So the knee is a hinge type synovial joint, and it allows for flexion and extension, and it's formed by articulations between the patella, the femur, and the tibia. So so if we look at a typical picture you'd see in your textbooks, this is a lateral view. So this is the, if we cut the knee in half and look at it from the lateral point of view, you get the femur, you get the tibia, and you get the patella, which is the kneecap. Now, if we look at a cadaveric image to get a more realistic view, you've got the femur here, you've got the tibia here, and you've got the patella as well. So the knees form articulations between these three bones, and the joint surfaces are lined with the hyaline cartilage. Also just wanted to add that the articulating surfaces of the knee contains the tibiofemoral joints and the patellofemoral joints. All these joint surfaces lined with the hyaline cartilages, and you have the medial tibiofemoral joint and the lateral tibiofemoral joint, which can be appreciated on this image. So the muscles and tendons provide structural integrity of the knee joint, and the main joint contributing to the knee is the quadriceps muscle. So it comes in the name, it's made up of 4 parts. It's got the part made up of the rectus femoris, the vastus lateralis, the vastus medialis, and the vastus intermedius, which is located beneath the rectus femoris. And the most important set are the vastus lateralis and the medialis that contribute to the joint stability. And you also have the patellar ligament, so if we say this is the patella, this would be the patellar ligament, or just over here. And movements of the knee joint. So primarily, the knee can flex and extend. Flexion is mainly by the hamstrings and these other muscles, which we'll go through in greater depth later on during the talk. And extension is primarily by the quadriceps muscles. The knee can also, you can also do lateral and medial rotation, but this can only occur when the knee is flexed, because when the knee is not flexed, the medial and lateral rotations will occur at the hip joint rather than the knee joint. And these are just some of the muscles that are related to the knee, which we'll go through in further detail. Can anyone tell me the tendon of which muscle group attaches to the patella? If I tell you this is the femur, so this area would be the thigh. Yeah. Yes, the quadriceps tendon. So it's a quadriceps femoris tendon, and the role of the patella, it's the kneecap, so it increases power of the knee extensor, and it basically stabilizes the knee joint to reduce any frictional forces that go over the knee. Okay. So we'll just talk about the extracapsular ligaments of the knee. So just to go over basics, a ligament is a fibrous connective tissue that attaches bone to bone, and it usually serves to hold structures together and keep them stable. So we'll just go over the patellar ligament first. So it's a distal expansion of the Quadriceps femoris tendon, and it's located at the anterior portion of the knee joint. And then we've got the lateral and the medial collateral ligaments, which in your OSCEs you would test when you do your knee exam. So the lateral collateral ligament, which is this one over here, it protects the lateral side of the knee joint. It's also known as the fibular collateral ligament. And then the medial collateral ligament, it protects the medial side of the knee joint. And you can just read these a little more detail. The Inter-Intra-Articular Ligaments, the main ones you need to know are the anterior cruciate ligament and the posterior cruciate ligaments. So the anterior cruciate, so this is the anterior image. So this is the anterior cruciate ligament. So it basically attaches the anterior intercondylar region of the tibia with the medial meniscus, and it ascends posteriorly to attach the femur as well. And the main role of this is that it prevents anterior displacement of the tibia and posterior displacement of the femur. And this is commonly damaged or ruptured in sports injuries. And the key thing in history, if someone has damaged their anterior cruciate ligament, the kind of history you'd get was, I don't know, a 36-year-old female was playing football in a field. As she was running, she heard a sudden pop, and within a couple hours, there was swelling on the knee joint. So the typical pop that you get is a sign that there has been an anterior cruciate ligament tear. And on clinical examination, this can be assessed by the anterior drawer sign, which you'll need to know for your OSCEs. And then with the posterior cruciate ligament, so it's located in the posterior intercondylar region, so between the condyles, and it goes to the anteromedial femoral condyle as well. And this prevents displacement of the posterior tibia and displacement of the anterior femur. And it also helps with femoral stabilization when walking down the stairs. And if this is damaged or ruptured, the clinical assessment you would look for would be, you'd see that when you do your posterior drawer sign, the patient is unable to, you're unable to do the posterior drawer sign. So we'll go over that. I'll just go over the anatomy first. So just to reinforce again, if you hear a pop in the knee, what has ruptured, or what do you have a tear in? Yeah, ACL. So this is quite common. You'll see it on PassMed as well, and you'll see it on your exams in terms of diagnosis. So it just means that you've got a tear in the ACL, and that's your posterior cruciate ligament. And so generally for these injuries, your treatment would be RICE, so which you would have learned before. So rest, ice, compression, elevation, and then you'd see it. Usually they may resolve spontaneously as well after you do RICE. So within the knee, you've got synovial fluid sacs called bursa, and these reduce wear and tear of the joint. So you've got the suprapatellar bursa here. So if we, so this is the lateral view, this is the anterior part of the knee, that's the posterior part of the knee. So suprapatellar bursa, the prepatellar bursa, the infrapatellar bursa, and posteriorly you get the semimembranous bursa. And in your clinical examination for the OSCEs as well, you will be palpating this region to make sure that there are no abnormalities. If you are able, when you do your OSCE exams, if you're able to appreciate a ripple through the medial or the lateral aspects of the knee, those are signs of pathology. So this is something you'd also be looking for in your clinical exam. So then moving on to the menisci. So the meniscus of the knee, they basically increase the congruence of the joint articulation. They are C-shaped pads of fibrocartilage, which act as shock absorbers, and they protect the knee joints. And they're attached at both ends to the intercondylar area of the tibia. So this is a cross section of the knee. So if this is the ACL and the PCL, this would be the medial meniscus. This would be the lateral meniscus. And it attaches to the ends of the tibial condyle. So this would be the medial condyle of the tibia, and that would be the lateral condyle of the tibia. And the medial meniscus, so the medial meniscus is fixed to the tibial collateral ligament, which makes it more prone to injury. You get meniscal tears, which are often seen in clinical practice. Here's just another image just to reinforce what we've gone through to make things a bit clearer. So earlier we looked at cross sections of the meniscus. So this is, if you look at it from the front, you've got the medial, the lateral, you got the anterior cruciate ligament, posterior cruciate ligament, and the medial and the lateral collateral ligaments. So just to reinforce what we've just said, if we look at this case and you get a patient, a 25-year-old footballer who twists his knee on the pitch, he's got excruciating pain, and he gets an MRI done, and you see this abnormality here. This is a sign of a meniscal tear and damage to the intracapsular meniscus. And when patients have this, they can also present with gradual swelling of the knee, but you don't need to know that at your level just now. So just clinical application with knee injuries, you can get fractures at the distal femur, the patella, the proximal tibia, at the fibula, basically all the bones that contribute to the knee. You can also get injuries at the soft tissues. You can get dislocations at the patella, at the tibia, and you can also have injuries to the meniscus, as we've just seen, and to the ligaments. And as we went through, the anterior cruciate ligament presenting with a pop on the field. So we'll move on to bones of the leg. So can anyone just tell me, between the knee and the ankle, what are your two major bones? Yeah. So tibia and fibula. So we'll just go into that in a little more depth. So the tibia is the weight-bearing bone. It's the larger one of the two. This bone articulates with the distal femur to form the knee joint, as we've said. The proximal end is widened to form the tibial plateau. Laterally, you've got the fibula, and the distal end is the lateral malleolus, if we look down here, the distal end, you have the lateral malleolus and the medial malleolus, which contribute to forming the ankle joint. So as we said, in the proximal region, it's widened. You've got the lateral condyle, the medial condyle, and an intercondylar eminence with a pair of tubercles just up here. Distally, you've got a fibular notch and you've got the medial malleolus. And then in the shaft here, you've got the anterior border. Sorry, this is meant to be tibial tuberosity. So if we look at this picture, this is an anterior image. You've got the tibial tuberosity, which if you feel just below your knee, you'll be able to feel a bony prominence, which is your tibial tuberosity. On the posterior border, you've got this line, soleal line, which is attached to one of the muscles, the soleus muscle. And laterally, you've got the interosseous border. So laterally here, you got the interosseous border. If we look at the fibula now, so it's lateral to the tibia. On the distal end, you have the lateral malleolus, which forms the lateral end of the ankle joint. And the fibula is not weight-bearing as it does not articulate with the femur. So the tibia is the weight-bearing one. And we mentioned earlier that the lateral border of the shaft, so here is the interosseous border, which is attached to the membrane. So this, if we look at this image here, there is a membrane that connects the shafts of the tibia and the fibula. So if we look at a cross-section now, cross-section of the tibia, you can see anteriorly, you've got this bony prominence, which is the tibial tuberosity. And this is, you get the lateral condyle and the medial condyle, intercondylar eminence. This would be the fibular head. And these are just a few tubercles that can be appreciated laterally and medially. So can you remember from what I've said just a couple minutes ago, which part of the tibia gives attachment to the interosseous membrane? Is it the anterior border, lateral surface, lateral border, or posterior surface? Yeah, perfect. So it's a lateral border. Okay. So we're moving downwards. So we'll move on to the ankle. We finished with the leg. So ankle joint. So the ankle is a synovial hinge joint, and it's formed by three bones, the tibia, the fibula, and the talus. So the tibia, the fibula, and the talus, which is one of the bones of the feet. Movements of the ankle, it can dorsiflex, so flex upwards. It can plantar flex, go downwards, and it has a small amount of abduction and adduction, inversion and eversion. And there are three primary joints that are formed in the ankle. So the medial malleolus and the medial talus are one joint, the lateral malleolus and the lateral talus, and the tibial plafond and the talar dome, just this area. So we'll just quickly go over the ligaments of the ankles. So you've got mainly the lateral collateral ligaments, the medial collateral ligaments, and the syndesmotic ligaments. So there are three lateral collateral ligaments, and for the medial, you just need to know that there's the deltoid ligament. So lateral ligaments, so you've got, So the lateral ligaments, it originates from the lateral malleolus, just here. So from the lateral malleolus, from the distal fibula, and the function of this is to resist over inversion of the foot. So the anterior talar fibular ligament here is located between the lateral malleolus and the lateral aspect of the talus. So this is the talar bone. You have the posterior talofibular ligament, which again is from the lateral malleolus to the posterior aspect of the talus. And then you have the calcaneofibular ligament, which is between the lateral malleolus and the calcaneus bone, which we will go through in the bones of the foot section. And for the medial ligament, just know that there's a deltoid ligament which attaches to the medial malleolus. And opposite to the lateral ligament, the function of the medial ligament is to resist over eversion of the foot. So we're just going to quickly look at some ankle x-rays. So if you get an x-ray that you need to look for any ankle pathology, this would be the tibia, the bigger bone. This would be the fibula, so lateral to the tibia, and you're looking at the talus. So we've got an x-ray here. So a 23-year-old female fell whilst out drinking. She had high heels on and went over on her left ankle. She's got significant bruising and swelling to her left lateral malleolus, and she's very tender over her left medial malleolus. So lateral and medial. So we're looking at this from the front, and then we want to look at the x-ray from an angle as well. So can anyone tell me where they see a fracture? And there's more than, yeah, perfect. So it's a bimalleolar fracture. We've got a fracture in both the tibia and the fibula. And laterally here, you can appreciate that it's been displaced as well. And so this needed to be fixed in theater with plates and screws. Does anyone know the classification for ankle fractures? There's a special classification for ankle fractures. Okay, that's fine. I didn't know it until I was in the later years. Yeah, Weber classification. So so you have the Weber classifications, which will be one of the most easiest classifications of any fractures. So a Weber A means that the location of the fracture in its classification is related to where it is to the level of the syndesmosis, which is basically the area, the fibrous joint held together by the ligaments. So Weber A is below the level of the syndesmosis, Weber B is at the level of the syndesmosis, and Weber C is above the level of the syndesmosis. So the higher the fracture, the higher the chance of syndesmotic disruption and ankle stability, and the higher the chance that it needs to be fixed in theater rather than conservatively. So because this is a bimalleolar fracture, it's unstable if it's not fixed in theater. So we've got another case here. So if you have, say this is a 50-year-old man who slips over while rushing to catch the tube, and ankle is severely deformed, unable to weight bear. What can you appreciate here? So again, lateral and medial malleolus fractures. It's at the distal end of the tibia and the fibula, and it's an unstable joint because the talus has shifted and dislocated. Okay, We'll move on from the ankle to the foot, just in the interest of time. So the bones of the foot are the tarsals, the metatarsals, and the phalanges. How many tarsal bones are present in the foot? Does anybody know? Yeah, perfect. So you have 7 irregularly shaped tarsal bones located proximally, and then you've got so these are the tarsals, then you've got the metatarsals, which connect the phalanges to the tarsals, and you've got 5, 1 for each digit, and then you've got the phalanges, which are the toe bones, and each toe has 3 phalanges, except the big toe, which only has 2. So you have the proximal, intermediate, and distal phalanges. So, the proximal, with the foot can also be divided into 3 regions: the hind foot, the midfoot, and the forefoot. So the hind foot comprises of the talus and the calcaneus. The midfoot comprises of the navicular, cuboid, and the cuneiforms. Forefoot is the metatarsals and phalanges. So the talus functions to transmit forces from the tibia to the calcaneus, and no muscles originate or insert here. Hence, there's a high risk of avascular necrosis. So that's a key point to remember. There's a high risk of avascular necrosis. The calcaneus, which is the heel bone, the function of this is to take the weight of the body, and the heel also hits the ground when walking. In the posterior aspect, you've got the calcaneal tuberosity over here where the Achilles tendon attaches. And then with the midfoot, you've got the navicular, which contains a tuberosity for attachment of part of the tibialis posterior tendon. You've got the cuboid and the 3 cuneiforms. And I'll let you read this just because in the interest of time, we've got to go through still a few more things. And in the forefoot, you've got the metatarsals. So the 5 of them between the tarsals and the phalanges. And then proximally, you've got the tarso-metatarsal joints. And laterally, you've got the intermetatarsal joints, and distally, you've got the metatarsophalangeal joints. So proximally tarso-metatarsal, laterally intermetatarsal, and distally metatarsophalangeal. And the phalanges are the bones of the toes. And as we said before, they all have 3, except for the great toe where you only have proximal and distal and no middle. Just to reinforce what we said earlier, which bone has a high risk of avascular necrosis? Yeah, the talus bone, because no muscles originate from it or insert to it. So the vascular supply is dependent on the facial structures that surround the bone. So we'll just go over the muscles of the gluteal region. Okay, so the biggest muscle, the main muscle in the gluteal region is the Gluteus Maximus. So it's this big, large muscle here. And the main function of it is to extend the thigh. And it also assists with lateral rotation. It is innervated primarily by the inferior gluteal nerve, and it attaches to the posterior gluteal surface of the ilium, sacrum, and the coccyx of the spine. And distally, it attaches to the iliotibial tract and the gluteal tuberosity of the femur. And then we have the gluteus medius. So it abducts and medially rotates the lower limbs. So this is important in preventing a pelvic drop of the opposite limb. And this is innervated by the superior gluteal nerve. And proximally, it attaches to the gluteal surface of the ilium here, and it distally attaches to the lateral surface of the greater trochanter here. And then you have the gluteus minimus, which can't be appreciated on this image. You can appreciate it here. And the function of it is to abduct and medially rotate the lower limb, and both the gluteus medius and the minimus, they're important in preventing a pelvic drop of the opposite limb. And this is also innervated by the superior gluteal nerve. It attaches to the ilium as well, and distally it forms a tendon inserting into the anterior side of the greater trochanter. Okay, I'll let you read that in your own time. So as I mentioned before, the main function of the gluteus medius and the minimus, they help prevent the pelvic drop of the opposite limb. So, and they're both innervated by the superior gluteal nerve. So in order to test whether these muscles are functioning and the pelvis is stabilized, you can assess the Trendelenburg sign. And normally, if you lift one leg up, you should not get a pelvic drop. However, if you have injury to the superior gluteal nerve and it's affected one of the two muscles, you can get a pelvic drop, which is also known as the positive Trendelenburg sign. And usually this pelvic drop happens on the unsupported leg. Okay, so the deep muscles of the gluteal region, so you've got the piriformis muscle, the obturator internus, the quadriceps femoris, and the superior and inferior gemmelli. So most of these are involved in lateral rotation and abduction, and the quadriceps femoris is mainly, it functions to laterally rotate. So this is a picture to see the deeper surface. It's not located in the superior aspect. So in this picture, the Gluteus Maximus has been taken out to expose the deeper structures, so you can appreciate the muscles here. And I'll let you read the proximal attachment and distal attachment in your own time as well. Just to quickly ask, does anyone remember what the innervation of the Gluteus Maximus is? Yeah, perfect. Perfect. Okay, great. So we'll move on to the anterior thigh muscles. So generally, the anterior thigh muscles act to extend the leg at the knee joint, and they're innervated by the femoral nerve, so L2 to L4 specifically. There are three major muscles, and we'll look at it in more detail here. So you've got the iliopsoas muscle, which is actually two muscles, the psoas major muscle and the iliacus. So these both comprise of the iliopsoas muscle. You can read the innervation and where it attaches, but I just want you to familiarize yourselves with how to appreciate the location and of where these structures are. So on a cadaveric image, you'd find it here. The sartorius muscle is this big structure here. And on this image, it's just over here. And the pectineus muscle is a bit deeper. it is located here on a cadaveric image, and you can't appreciate it here. So the iliopsoas muscle flexes the thigh at the hip joint. The sartorius flexes, abducts, and laterally rotates the hip. And because it extends down to the knee as well, it also flexes the knee. And the pectineus muscle adducts and flexes at the hip joint. So that one there. And then we'll just talk about the quadriceps femoris muscle. So we mentioned briefly about this earlier when we spoke about the knee. We'll just go into a bit more depth here. So it's made up of four. There are four parts: vastus lateralis, medialis, intermedius, and the rectus femoris. So in the image here, the rectus femoris is located in the center, laterally vastus lateralis, medially vastus medialis, and the rectus femoris is located under, the vastus intermedius is located under the rectus femoris muscle, so you can't really appreciate it over here. The vastus lateralis extends the knee joint and functions to stabilize the patella. Vastus medialis extends the knee joint and stabilizes the patella, so they'll stabilize the patella. Vastus intermedius also extends the knee joint, and the rectus femoris flexes the thigh at the hip joint and extends at the knee joint, and they're all innervated by the femoral nerve. We'll just quickly look at the medial thigh muscles. So the medial thigh muscles generally serve to adduct the hip, and it's made of 5 major muscles. They're all primarily innervated by the obturator nerve, and its arterial supply is the obturator artery. Just to give you a brief idea of where these lie, this is a cross-section of the medial thigh. So ignore this bit, that's the anterior compartment muscles and posterior. So we're looking at this bit. So you have the adductor magnus, which is the biggest one of them all, the largest muscle of the medial compartment, the adductor longus, and the gracilis muscle. And you can also appreciate the obturator externus here, and the adductor brevis. So I'll let you read this in your own time. And when you're revising, this is just another nice picture. It's just another realistic image of where things lie, and the relation of the muscles to also the femoral nerve, artery, and vein, and the presence of the great saphenous vein that also travels on the superior aspect of the medial aspect of the thigh. Okay, so we'll just quickly go through the posterior thigh muscles. So your posterior thigh muscles are known as the hamstring muscles, and generally they extend at the hip and they flex at the knee. And there are 3 major muscles that make up the posterior thigh muscles, and they're primarily innervated by the sciatic nerve, so L4 to S3. And again, so the biceps femoris, there's the long head and the short head that comprise the biceps femoris. This functions to flex at the knee and extend at the thigh at the hip, and it also laterally rotates at the hip and the knee. So you've got the long head here, which is innervated by the tibial part of the sciatic nerve, and then you've got the short head here, which is innervated by the common fibular part of the sciatic nerve. And it's attached to the long head is attached to the ischiotuberosity, and the short head is attached to the linea aspera of the femur. Of the femur, And distally, the heads form a tendon which inserts into the head of the fibula, just over here. And then we've got the semitendinosus muscle, which functions to flex the leg at the knee joint and extend the thigh at the hip. It also medially rotates the thigh at the hip joint and leg at the knee joint, and it's innervated by the tibial part of the sciatic nerve. Proximally, it attaches again from the ischial tuberosity of the pelvis. So I've got also the pelvis over here for you to just understand where the ischial tuberosity is. So it's just here, if you just put this over here. And distally, the semitendinous muscle attaches to the medial surface of the tibia. So this is the tibia. And then with the semimembranous muscle, it functions to flex the leg at the knee joint, extend the thigh at the hip, medially rotate the thigh at the hip and leg at the knee joint. And again, it's innervated by the tibial part of the sciatic nerve. And this again is proximally attached to the ischial tuberosity, however, more superficially, and distally, it's attached to the medial tibial condyle. This image here is just a cross-section of the thigh muscles, just so you can get a picture where things are. So this is the anterior part of the thigh and the posterior part of the thigh. And just to look at a cadaveric image to make this, to see what you'd appreciate in real life, that's what the muscles look like. So the biceps femoris, semitendinous, and the semimembranosus. So this is just a quick summary for you to look at in your own time when you're revising of the muscles and their relations to the bone.